Okay, and welcome again, everyone. I'm so glad you could make it. I'm sorry that we had to reschedule this for the Thursday before, but we're hoping if you're joining us after the fact and watching this on YouTube, then hello from the past, and we're so glad that you're joining us either way. So just a couple of things to announce. Regional competition is well on its way. Whether you're preparing for that for April 6th and 7th, we're so excited to have you. If you're here just because you're preparing for next year, then we're really excited to say that we do plan on opening registration around a similar time in this upcoming year for the 2025 competitions. So no matter when you're joining us, we're really excited to have you. We hope that we can clarify some things for those that are going to be competing in the regionals next weekend. So looking forward to that. If you guys haven't taken a look at our research survey, please go ahead and find that in one of our blog posts, and you can find more information for how to participate. I think that's about all I have, so I'll turn things over to Dr. Haggerty to teach us some some histology, I'm sorry, and give us some examples of some oral questions.
All right, I am going to share my screen. And give me a second to get set up here. There we go. Can everybody see that? All right, got a thumbs up. Thank you, Dr. Pesquera. And it would help everyone avert your eyes. Hold on one second. All right, let's try that again. Oh my goodness. Can we see that?
Right now I can see your, not in presentation mode, but I can see your screen.
Great.
Dr. Haggerty, you're on the very last or almost last slide of your
Yeah.
presentation.
Technical difficulties. All right, let's try this again. How about now? All right, good. Sorry about that. All right. And then, oh my goodness. I can't see the polling option. There it is, polls. All right. All right. Now we're rolling. Sorry about that. Okay, so this is going to be set up just like we did in our local competition review for after you had all of your tutoring sessions, and then basically me and the other co-founders will be giving you examples of how the written exam will look based off of the more so regional objectives that are on the website. So with that. So lecture objectives, this is going to, I am so sorry. Let me turn off my email so we're not getting annoying buzzing noises. We are going to be referring to the learning objectives on the website. I just put them here because there are many to refer to. And then also a reminder to refer to the exam information. We already kind of know how the oral exam or the written exam goes, multiple choice questions. You'll be using your own device. It's through Google Form, but the oral exam is going to be something new to you. So make sure you go to the website and refer to that information. So we're going to go ahead and start off with a multiple choice question. I am going to bring up a poll. So you are going to be answering through the poll. So which of the following gland types releases secretions through the rupture and breakdown of the entire cell? And we do have 11 participants. So yeah, I'm just going to wait till we get about 5 of them participating. I think that's great. So I'm going to go ahead and end the poll now and share our results. So we had a lot of people say either apocrine and holocrine. So our answer to this question is going to be holocrine. This is a type of cell where the mature cell actually dies and becomes the secretory product itself, as we can see in the image. And when we go over the information that Dr. Frank had presented in his presentation, we did cover merocrine versus apocrine versus holocrine. So again, some of you had chosen apocrine, and this is this is understandable because this cell also, to allow secretion to occur, it pinches off a portion of the cell, which is secreted. But the question was basically the entire cell ruptures and breaks down. So when studying this, I would just make sure that you do know the differences between the different types of secretions within the cell. These relate back to our exocrine glands. And then also you should be aware of where these types of secretions or cell types are going to be occurring. So here is our next poll. Which image represents adipose tissue? All right, I'm gonna end the poll. This is really great. So we have the majority of you answering A, and then we also have some of you answering C. So the answer to this question is image A. And we kind of talked about this in our last review session, but can somebody put in the chat why they think it is A? Lipid doesn't show on the stain. Great. So you can see this kind of empty-like area in the cell. William, you say large pouches of lipid. So like Michael had pointed out, there's the area here is where the lipid is, but it actually gets washed out. But that is where the lipid would be. You are correct. And then that because of that, the nucleus is pushed to the side of the cell. Those are really great characteristics. Can anybody take a guess of what C is? That was what other people had chosen for their answer. What type of fiber specifically is shown in image C? Reticular, very good. So in B, we have elastic fibers, and then in C, we're showing reticular fibers. And a lot of you would think, well, how am I supposed to know that? So this is something that we have shown repetitively in your study guides, and we had talked about covering specifically in your learning objectives, knowing the difference between different fiber types. So I would definitely go to your learning objectives for this. It talks about knowing about different connective tissue, which would be adipose, and then those fibers being elastic fibers, reticular, collagen fibers. And when we review those, we have specific stains for things like elastic and reticular fibers. And that's basically what we're seeing here. And then I even have more information. This is taken from Dr. Bill Frank's slide. And this is just a reminder, these are all components of connective tissue, right? So again, we talked a little bit about different cellular types. You have adipose tissue or adipocytes shown here. We also have fibroblast cells. And then we have other things like fibers. So remember what he talked about. Connective tissue is made up of cells, but also fibers, which creates kind of like the rebar or the meshwork, and then the ground substance with this, which is a gelatinous kind of material, which is our concrete. So just be sure to review all those different components of connective tissue. Okay, we're going to start another poll. So which of the following best describes the process of chondrogenesis, identifying the cells and morphology involved? That's worded a little weird, but basically you want to think about the process of chondrogenesis and be able to identify cells and their morphology involved. All right, looks like people are thinking on this one. I got one more answer, so I'm going to end the poll now. Share my results. So this was a tight call between choice A and choice B. So let's think about this a little bit. I would first go to what the words are telling you. So we can see some words that say osteocyte, chondroblasts. Anytime you see cyte, that's a mature cell. Anytime you see blasts, that's an immature cell. So then we would just want to go to that first portion of our word and think about, you know, what kind of cell is this telling me? So adipocytes. So we just talked about that. So this is going to be adipose tissue. Fat, we want to think fat tissue. And then we have chondrocytes and osteoblasts. So chondrocytes, chondro, we want to think about cartilage. And osteoblasts, we want to think osteo, we want to think bone. So if we go back to our question, we were talking about the process of chondrogenesis. So let's start with this question here, because it was one of the most chosen: differentiation of adipocytes to chondrocytes. So we're talking about mature adipose tissue to mature changing. Differentiation means just changing or morphing into chondrocytes. So we would know that this answer is not true because adipocytes would not differentiate into chondrocytes. So then we go to the second most chosen question, B, which is our answer. And so the changing of the morphology of mesenchymal cells, right, or differentiating of mesenchymal cells into chondroblasts. And we need to know that mesenchymal cells are basically a cell that can morph into a lot of different things. And then ultimately they're going to form hyaline cartilage. So this will go back to Dr. Oriana's slide on chondrogenesis. And I think she did a really good job laying out the process shown here for us. So again, this is relating back to those mesenchymal cells will proliferate and differentiate. So they will multiply and they will change into chondroblast cells. Which then will start to deposit a matrix around themselves. And once that matrix is deposited, those chondroblasts will turn into chondrocytes. And then this is just a note that those mesenchymal cells directly adjacent to the developing cartilage becomes perichondrium, which is shown here. And then while staining, your chondrocytes are densely stained and encased in lacuna. And this is something similar that we see in our bone. And then there's two different types of growth, which she shows very well here, the interstitial growth. So these chondrocytes will undergo mitosis and again, multiply or mitosis, and they will mature and then continue secreting their matrix. And she's showing with the arrows in the direction they will be causing growth to occur. And then appositional, this will occur at the perichondrium or along the edges and differentiate into chondroblasts, which will secrete that cartilage matrix and grow the cartilage at its surface. So let's ask our next polling question. And while you guys do that, I'm just going to take a look at the questions in the chat. Do most connected tissues have a few mesenchymal cells laying dormant and tissue waiting to regenerate if the fibroblasts are lost?
Dr. Haggerty, I just put an answer in the chat.
Oh, perfect. Yeah. So Dr. Peterson said that many tissues have small population of stem cells or mesenchymal cells that can be induced under, I assume you want to say mitosis there? Yeah, okay, great. Yes, and that is a perfect point. Mesenchymal, another word for that is stem cells. These are cells that generate into different cell types. Okay, so I am going to go ahead and end the poll here. So a lot of us the majority of the group is answering choice A. Striated muscle, rhythmic, involuntary control. So going back to the question here, which best describes the contractile characteristics of the muscle portrayed to the right? So I did mention this is a second order question. Being that this is a regional competition, we're going to ask more challenging questions. A second order question basically means I'm going to ask you a question where you have to identify what you are seeing first, right? And then you're going to have to, once you know what I am showing you, you'll have to answer that question. So, for example, a first order question is identify this picture here, right? So if I make it a second order question, you first have to answer that question in your head before you can answer the question that's shown here. So I look at the image to the right. I can identify this as, if anybody wants to put this in the chat, what kind of muscle tissue is that? I guess cardiac. That is a very good guess. We can see some striations. It's not really multinucleated. We see a little bit of branching. If you can look a little closer, you can see these darkened lines here. Those are intercalated discs. So again, being a second order question, you're not actually identifying the picture. You first have to say, oh, what is that? That is cardiac muscle in order to answer the second question, which is which best describes the contractile characteristics. So again, a lot of you chose A, which is the correct answer. This muscle is cardiac. It is striated muscle. And it causes a type of rhythmic contraction, which is under involuntary control. So I put together kind of another slide for you all. And this is adapted from Dr. Oriana's information that she gave you to just break down the information a little bit more. So, and I wanted to make a really big note here. So when you're thinking about striated versus non-striated, you're thinking of the organization of actin and myosin. And we know these proteins as thick and thin filaments within muscle. And basically, all three types do contain actin and myosin. It's just how they're organized within the muscle itself. So because of its organization in skeletal and cardiac muscle, these muscles appear, and this should say striated here. So I'm going to take a moment to say this is striated muscle, the cardiac muscle. So make sure you recognize that. Skeletal and cardiac muscle are both striated because of the organization in these like sarcomere like structures, which are shown here and here. But in smooth muscle, it's kind of organized in a mesh-like structure. So that is why we don't see much striations. And then there's the control of contraction. How is this muscle innervated? So for smooth and for cardiac muscle, this is under involuntary control, which means I don't think, oh, I'm going to move a muscle and I move it. It just does it on its own. This is controlled by our autonomic nervous system. And then the muscle that is under voluntary control. So I want to move my arm, so I move it, is skeletal muscle, which is controlled by our individual spinal nerves. And then lastly, during contraction, how are these working? So for smooth muscle, these muscles are connected by gap junctions, but they when our body tells our smooth muscle to contract, it basically is contracting in concert or syncytium, which basically means it sends an electronic impulse, it releases the calcium, actin and myosin cause contraction, but because these cells are connected through gap junctions, they all do it in concert and at the same time. Skeletal muscle, we can actually contract one little muscle fiber or a whole muscle itself. And that'll, if you think back to how muscle is organized. And then for cardiac muscle, kind of like smooth muscle where these cells are all connected through those intercalated discs through gap junctions, but this is more of a rhythmic control, and it's also continuous. And I wanted to mention there's lots of ATP, so that means it has lots of mitochondria, so our heart can continuously pump. Okay. So let's start up another poll. Which sensory structure of the skin is in the dermis and detects deep pressure and fast vibration? Great. End the poll and share results. So majority of you had chose choice C, which is correct. This is a more simpler schematic, which just kind of shows where, and in our learning objectives, we had asked you to know the difference between Merkel's disc or Merkel's receptor, Meissner's corpuscles, and Pacinian corpuscles. So the one that we're talking about here is in the dermis. And as you can see in that dermal layer, that's where our Pacinian corpuscle really sits. And this is going to be detecting deep pressure or fast vibration. So when we think about our other types of receptors, and this is from Dr. Spudik's lecture, we have, again, that Meissner corpuscle, and this is actually closely related to that epidermal and dermal junction. And this will detect light touch and slow vibration. And then the other one is the Merkel's receptor, which is more associated with the epidermis and detects fine detail, whereas our Pacinian corpuscle, as we see here, deep in our dermis, again, is deep pressure and fast vibration. And not really on your learning objectives, but I wanted to highlight again, there are free nerve endings that do come up to the epidermal layer. And these are nerve endings that really detect that, painful stimuli from the skin. Okay. Here's our next goal. Which structure is not part of the portal triad histologically? So you should be thinking, where is the portal triad? What do you think about when you hear portal triad? And this is not technically a second order question, but it's just, not every time will we give you exactly where things are located in the STEM question. And again, being regional competition, it just makes it a little bit more of a difficult question. Okay, end the poll and share our results. So it looks like a lot of you chose A, the bile duct, and then C, the hepatic artery. So I'm going to actually pull up this image here. So the portal triad consists of the bile duct, our hepatic artery, and a portal vein. So we can see, and this is we've gone over some of the general histology of this. I would not give you this image and have you identify which is which on a histological image because that is not in your checklist, but it is important to understand what these structures are doing in the liver as part of your regional objective. So this is actually taken from a liver, and we can see the bile duct because it has simple cuboidal epithelium. We see our artery, we see it's inflated compared to this other venous structure, which is a little deflated, being our vein. And how this, sorry, I'm getting a little trigger happy, how this all works within the liver itself, and is basically being able to supply nutrients and then take nutrients out of, or detoxify things from the blood itself. So that portal triad is going to sit on a periphery of these liver, what they call in Dr. Spudik's lecture, a plate. It kind of looks like a little hexagon. So in the center of that is a central vein, and at its periphery is this portal triad. So you have a bile duct, portal vein, and hepatic artery. And we can see artery will be supplying nutrients to the tissue itself, but the portal vein will actually move blood from the periphery to the central vein. And this will travel through our hepatic sinusoids shown here and filter the liver cells to be processed, so like detoxification, where nutrients are metabolized, hemoglobin metabolized, and then the bile made by the liver cells will move away from that central vein into the bile duct to go into the gallbladder itself. So again, that question was asking what is not part of our portal triad, and that would be the central vein. Okay. So in what histological layer of the stomach will you find gastric pits? Okay, very good. I'm going to end our poll here. So we have a lot of people saying mucosa and submucosa. So this these gastric pits are really formed by mucosa. And the reason why I say that is because it's basically an invagination of this layer shown here. So it's outlined here, and this is taken from Dr. Spiedek's lecture. And again, we can see that invagination in this picture of the gastric pit and gland itself. This is all epithelium. So remember, at the top of the or closest to the opening of our lumen is the mucosa, and at the very superficial edge of that is the epithelium. So we can see that here, it's just invaginated or folded in on itself. So that's how we get the mucosal layer. I'm so sorry. And then going back to this slide again from Dr. Spiedek's lecture, so that mucosal layer is folded into the gastric pit shown here and the glands. Cells lining the lumen of the stomach and the gastric pit are mucus secreting cells. This helps to control the pH of all that acidity, and then and protecting the stomach from acid and gastric enzymes. And then another learning objective, and you should be aware of, are other different cell types within the gastric gland and pit itself. Okay, next question. Where would you find the renal corpuscle? Renal. So you should think renal. Where is renal? Okay, so I'm gonna end my poll here. Okay, so we had a lot of people answer B and then C. So I'm going to pull up our answer. So it's actually the renal cortex. And I just wanted to pull out a slice from a kidney here. So this is the outer edge of our kidney, and then going into what we call the renal sinus, or the center, kind of in the, towards the center of the kidney. I'm making sure that I'm saying this correctly. So towards our more superficial surface here, we have what we call the renal cortex. Deep to that is the renal medulla. And then this renal papilla is really part of the renal medulla. And this is where our filtrate will really empty into the minor calyx as urine and continue its journey through the ureter into the bladder, and to be disposed of from our system. So the renal corpuscle, which we can see are these little circular areas here, and I magnified that because they're a little difficult to pick up here histologically. And again, this is something that I just try to give you guys a little bit of context. I would not have you identify this on a histological image, but for your renal learning objective, just thinking about where these are histologically. And this was something that Dr. Veazey had gone over, talking about renal cortex versus medulla. So we can see, and these are very zoomed in images compared to the image that I showed you here, cortex to medulla itself. But in the renal cortex, you can see those renal corpuscles, which are here. And then we will also have your proximal tubules, distal tubules, and collecting ducts. And as we move more towards our medulla, we will start to see collecting ducts, distal tubules, loops of Henle, and vasa recta. Okay. I'm not sure where I had that extra slide in there. Sorry about that. So now at this time, I'm going to take the remainder to talk about the oral exam. So we'll take about 10 minutes at most at this portion. This is information that is also provided on the website. There's also an example on the website, but during your oral exam, you will be seated in chairs in the frontmost rows of a large classroom or auditorium, depending on where you're attending your regional competition. Chaperones will be allowed to observe the final competition in real time. So that means that anyone can come in and sit in the back of the room and see the exam take place in real time. And they will be in the back of the auditorium so that you can focus on taking the exam yourself. A question will be asked out loud by a moderator, most likely up front at a podium, and the question will be displayed on a projected screen. And then the question will be repeated a second time. You will have 60 seconds to answer the question. itself through your own personal device. This will be put together through a Google form. And as your answers are coming in, it will be monitored by volunteers grading the exam. And what will happen is these graders will monitor the answers coming in, and then we'll mark the answers that are wrong. We will basically stop. You will no longer receive points for your answers after you receive 3 wrong. So what this means is if you answer your third wrong at question 10, you get 7 points. So that's basically how these points are tabulated. You will not be informed when you get a question wrong. We would like you to continue answering the questions so that you get more experience answering questions like these. And then there will be a total of 30 questions altogether. So this will be added to as a cumulative score from your points from Saturday, so that we can pick a top student to receive financial funding to go to a summer program of their choice. Doctors Peterson or Piscaria, do I need to mention anything else, or did I miss anything?
No, but Michael's asking a good question. I think everybody would like to know. So
Yes.
just to clarify, so these are not multiple choice questions. These are what we would consider short answer questions. So you'll need to be typing in your response. And that's why Dr. Haggerty was mentioning that, reasonable spelling is what we're looking for. You don't have to be spot on. And that's why we're going to have proctors that are viewing those responses as they come in, so that they, as content experts, will be able to evaluate whether your response should be scored as a correct or an incorrect answer.
And then you said how many subtests are there, William? So this is the oral is a subtest itself. There's not like a test within the test. We're just basically asking you we call them clinical stems. So I'm just going to go to my first example so that you can get an idea of what that looks like. And if you have any other questions, you can feel free to put them in the chat. And then I did include the link at the bottom here, again, that relates back to this information on the website. Okay, so I am going to, let me go back. I'm going to go back because I'm going to try to set a timer here and see if we can get some answers. So, and I think what we had agreed upon was we were not going to put these in the chat. So we can just let you all answer at home and not see answers flowing into the chat. And then you can practice going through this. So don't put answers in the chat. Just, I'm going to time you and you're going to answer yourselves, write it down on a piece of paper. And then I can give the answer. Okay. So let me pull up my clock and my timer, and not 1 hour, but 60 seconds. Okay. So for the first question, I will read it out loud twice, and then I will start my timer. In the advanced stages of Lou Gehrig's disease, or amyotrophic lateral sclerosis, ALS, individuals often experience respiratory insufficiency leading to respiratory failure. This is due to the demyelination of peripheral nerves. Which pair of nerves innervates the diaphragm, and loss of those nerves would contribute to respiratory failure? So in the advanced stages of Lou Gehrig's disease, or amyotrophic lateral sclerosis, individuals often experience respiratory insufficiency leading to respiratory failure. This is due to the demyelination of peripheral nerves. Which pair of nerves innervates the diaphragm, and loss of those nerves would contribute to respiratory failure? Okay, that is 1 minute. So that gives you an idea of how that runs and how much time you have to answer a question. I did start the timer after I asked the question the second time. Does anybody want to share their answer in the chat? Phrenic nerves. Yes, very good. Okay. And then I can give you, I'm so sorry. I'm so clicker happy today. Okay, so that is phrenic nerves. Phrenic, you think C3, 4, 5 keeps the diaphragm alive is what we say. You do not know, those are the spinal nerve levels. You do not need to know that for the exam. But if it helps you remember, that's what keeps the diaphragm alive. You can say that to yourself. So that, yes, phrenic nerves is what innervates the diaphragm. And we know that the diaphragm is the major respiratory muscle, right? We can talk all day about other types of muscle, intercostal muscles and such, but the diaphragm is the big player, respiratory muscle. So this is the type of clinical stem that you will be getting. We'll give you some type of disease or a case that your patient may come in with, a little bit of symptoms, maybe a test that they get done. So a big thing of this is you don't really need to know the disease. I think a lot of people get hung up on, well, I don't know what ALS is. Listen to the facts that we're giving you. Demyelination, you should know what that is. You know what myelinates a nerve, right? You know what myelination helps with. Peripheral nerves. So you should start thinking, what types of peripheral nerves do I know? And then what innervates the diaphragm? So again, thinking about the factual information we give you, and then the question itself, and things in the question like respiratory failure. So diaphragm, what's going to help with respiration? So let's go to our second question here. And you're just going to think and write down your answer, which is image A or image B. We're not going to do a poll or put anything in the chat. And I'll do the same process again. A 45-year-old female reports to her physician she has no energy to do any housework, gardening, or play with her grandchildren. She reports that in the last 6 months, she has gained 10 pounds. Her blood work reveals lower than normal levels of thyroid hormones. Which of these images best represents the results of her biopsy? A 45-year-old female reports to her physician she has no energy to do any housework, gardening, or play with her grandchildren. She reports that in the last 6 months, she has gained 10 pounds. Her blood work reveals lower than normal levels of thyroid hormones. Which of these images best represents the results of her biopsy? I'm starting the timer now. Okay, that is 1 minute. So if you can just put somebody can put their answer in the chat, image A or B, or just A or B. A, very good. A. So it is actually image A. So with this, it's a little tricky. We are not pathologists. We're not teaching you pathology. But you do know from your atlas and some images that what a thyroid tissue sample should look like under normal conditions. Okay, so 45-year-old woman. So from this first part, again, we're just setting the stage. We're giving you a clinical scenario. She's low energy, right? She's also gained weight. This sounds a little bit like hypothyroidism. Do you need a physician? Do you need to know what entails with all of that, or pathologist? Not really, because what we can allude to here is we're talking about thyroid and thyroid hormones. And when we give you these two pictures here, because we know what normal tissue looks like, we can basically tell that this here is the pathological tissue. Now, the other thing too is just thinking about, we do tell you there's lower than normal. So if we're looking at the size differences in the colloid that's collecting in these thyroid follicles, we can see that the image on the left is a lot smaller. But again, you are not learning pathology, so that's why the images were chosen the way that they were. And I'm trying to help you kind of establish and go through how to take these types of questions. So I think the other thing too is when your time is up, it is up during the exam. So we will turn off the ability to input answers for these questions when the exam is taking place. And that is just so that we can continue to move on. So there will not be the ability to say, well, wait, I did not put an answer into the response section, if that makes sense. What are those weird dark pink rings in the middle of the colloid on the left side? Are we talking about this here? Yeah. I want to say that's just how that's stained, but I could be wrong. Dr. Peterson, are you aware of what that may be? You're muted.
I think the other thing to point out is that you can see a really consistent capillary blood supply over on the image to the right, which is really important for delivering the basic components of building thyroid hormones, which you just cannot see over on image A.
Yeah, let's see that. Okay. And I think that's all that I had. I included some more imaging links, and then again referencing the previous tutoring sessions. Dr. Peterson and Piscira, do you have anything to add about oral questions?
No, just maybe really quickly to William's question, the subtest, William, that's just a phrase we're using for the different types of exams over the 2 days of the regional competition. So on Saturday, you'll actually take 3 different types of exams, the written exam, then you'll have the lab practical exam, and then you'll have the standardized patient interaction, and that's pretty well described on the website, but I think maybe Dr. Piscura is going to briefly mention.
So, do all of those have the same scoring system that you described?
They all have a different scoring point total, but the written exam is multiple choice. Recall that the lab practical is multiple choice, and with the standardized patient, you will have the option of asking yes and no questions to the standardized patient after they've read their little scenario, and then you will have a list to choose from. So on Sunday, that's the only day where it's a kind of fill in the blank. You have to type in your own answer without any kind of hints from the Anato-Bee co-founders.
Thank you, Michael.
Okay.
Michael is suggesting you check out the website, which we also suggest, but we're happy to answer any questions you have.
Yeah, click on the link and I'm looking through the information.
Yeah.
I just dropped that link back in the chat. And the other thing I wanted to say too is that we don't expect you to be content experts in any of this. I think it's this exposure that makes you the content expert with time. So the point of this isn't really to show how many of these you can get right. It's more of to get the experience and the exposure to this information so that when you do go on to, further education, that you're more prepared for those classes, which can be quite hard, without any previous exposure. So I think you're setting yourself up for success just by being here.
Yeah, and I want to also repeat basically what Dr. Piscira said. That's a big part of this. I think a lot of people are, I mean, of course, everybody wants the money and, but we're really trying to set up these exams or the competition to be an experience. So we're really trying to get you networking. We're trying to get you exposure to these types of questions. How do you assess? How do you take this exam? So I really hope that you guys do not feel bad about yourselves when you get a question wrong. I hope that when you get your scores, if you're not the top scorer, you don't feel bad about yourself. Showing up is a major accomplishment. And that in itself is amazing. And we're excited to meet all of you, and you all are rock stars in our eyes, and you should be extremely proud of yourselves for coming to the regional. And if you're not coming to the regional, you're just here to learn, that itself is an accomplishment as well. And you know us, you have our contact information. We would be happy to help you with anything involved with networking in the process, and even coming back next year if you're not coming to this year's regional competition. So you should be giving all of yourselves a big pat on the back. For the oral, yes. So for the oral examination, if you do not answer, can you leave it blank? You can leave it blank. Just keep in mind, you will get that answer wrong. So again, you have up to 3 tries to get, basically, if you get 3 answers wrong, we stop counting points. But you can leave, there's no pressure. If you can't answer the question, you don't have to answer the question. Okay, Dr. Piscari, do you want me to do the polls for you, or would you like to run them yourself?
I think I just found how to do it, but there we go. I can try it and see how I do. I apologize to when I'm newer to the polling system in Zoom, but I'm going to give it a go. All right, so I'm going to go over the anatomy questions. I just have 10 for you, and I think they're pretty straightforward ones, so we should be able to go through those pretty quickly. And then we're going to spend at least 5 minutes, which is how much time you can expect to experience with the standardized patients. And I'll just work through one example. There's one also listed on the website, but this will give you a chance to get, again, more of a feel, just like Dr. Haggerty had set you up with one there. So with that, let's go ahead and look at this. So lecture objectives, just go to your friendly website here, go to your learning objectives, and you'll find that there's a whole slot on the right of your regional objectives. And so those are going to be the new ones. That doesn't mean that you won't encounter any local objectives, but just as a reminder, if you've need a refresher for those local, make sure you go back and look at those. But I'm going to focus for these practice questions, since we already had a session on the local objectives, I'll focus these on the regional ones. All right, so first question here, I'm going to relaunch this poll. All right, you should see a new one here. So this is, which imaging modality is best suited for visualizing soft tissues, such as the brain or spinal cord, and is made using large magnets? Seeing a lot of good responses here. I think we got most people in here. So most of you had gotten that there was a kind of a key in here using large magnets. And so let's go to our answer. This is going to be your MRI. And so just as a reminder, magnetic resonance imaging is what MRI is standing for. So seeing that magnets should have been one key in there that you could see. So just as a reminder, other one that I had seen was CT. This is actually going to be a combination of X-rays from a bunch of different angles, and then kind of combines them into some cross-sectional imaging. And then the other one that I saw was ultrasound. And so what that's telling you is that ultrasound is telling you that there's some high frequency sound waves that are actually used to create these images. All right, great job though, everybody. Just a reminder, go to Dr. Bill Frank. He did a really good job of going through these. I will say some of this is a little bit more detailed than you need to know, so just focus on the main takeaways from these imaging modalities. We're not going to ask you anything too in-depth where you couldn't tell the difference between what we're trying to ask you. All right, so let's do next question. All right, so this is a good one, a very clinically important one. Which ligament stabilizes the knee by preventing anterior displacement of the tibia? This one I'm starting to see a lot of mixed responses in here. So kind of split across the board here. All right, so let's go into this a little bit. So the answer here is going to be your anterior cruciate ligament. I promise it's not a trick question in how these are named. In terms of the when something goes wrong, based on where a blow could be, those could be a little tricky to wrap your head around it. But in terms of what they're doing in a healthy patient, the names can kind of key you in into where they're providing stability. So here's a really good lecture slide. This is from Dr. Oriana from the musculoskeletal system presentation that she gave us on March 10th in this first review session. And so you don't need to worry too much about these specific attachment sites, but just focus on the fact that there's going to be both medial and lateral collateral ligaments. And so those are going to be providing support on either side. There are some other names for these, like medial telling you it's more on the tibial side versus on the lateral side telling you that it's more with this fibular. Makes sense based on where these bones are. And then you also have these cruciate ligaments. And so you can see that the anteriors could be preventing displacement anteriorly, so preventing this tibia from popping out towards the direction where I'm pointing my cursor. And then the posterior is going to do the opposite. So the names in there will actually kind of key you into how these knee ligaments are stabilizing the knee. This is just one that's very clinically important. The knee is a very commonly injured structure. So I do see a good question. Posterior will in fact prevent posterior displacement. That's a really good key in there. So just focus on the name for these ones and that should help you out a lot. All right, let's go to the next one. All right, so now I want to know, let me restart this poll. Which muscle is located in the back, extending from the base of the skull to the lower back? Notice how I didn't put any specific attachments in here. I'm not trying to quiz you on any of that, really. Some of the really specific ones you'll go into books, and there's a lot of these. Focus on the major attachments and keep things kind of broad as you're studying this for the first time. So we're saying extending from the base of the skull to the lower back, and we want to know which is responsible for movements like head extension and shoulder elevation out of these options. And I'll give you a couple more seconds to respond to that. They're doing a really good job with this one. All right, got most everybody in here, so really great job here. All right, so this is in fact going to be your trapezius. So you can see the attachment points are a little bit more complex than this, like I said. So we are originating from the skull, the nuchal ligament, spinous processes, all the way from C7 to T12. We've got attachment points on the clavicle, on the acromion, and some on the spine of the scapula. And so actions for here, we can do a couple of different things. We can abduct the upper limb at the shoulder through the scapular rotation. Then we also have this arrangement of fibers, whether you have our descending, ascending, and transverse fibers here. But what you can tell is if you do the movements, like they said, extend your head backwards or elevate your shoulders and feel the top of your shoulders where your trapezius is, and you should feel that muscle tense up a little bit when you're doing either of those actions. So that's another way that you can test these. You've got a cheat sheet on your body. Happy for you guys to use it during the exam. If you get confused by something, go ahead and feel your leg or your shoulder or your back if you can. All right. All right, so pretty good on that one. All right, next one. We had a really great lecture with Dr. Spudik about some neuroscience. So which lobe of the brain is primarily responsible for processing visual information? Kind of doing a really good job. All right, I think we got most people in here. Let's go ahead and share that. So you guys did really good. So this is in fact going to be the occipital lobe. And so this image was really helpful just to go back to some generic things you could put in here. Again, it's far more complex than this, but the primary centers are the ones that you should be focusing on. So the cerebellum is going to be more associated with movement and coordination specifically of that movement. The occipital lobe is really important for your primary visual cortex. Your parietal lobe is more associated with touch, and your temporal lobe is going to be more associated with your memory processing, your emotions, a lot of your sound also happening here. And frontal lobe we didn't cover. This one's also going to be really important for your executive functions, your decision making, your planning, your attention, and things like that. So if I'm boring you, it's either your frontal lobe is not really giving a lot of attention, or it's my fault and that I'm not going through these things with enough enthusiasm. So just kind of think about ways, and you've used each one of these lobes in situations that you can apply them to, like that, where if you think, oh, my vision got blurry when I did this, and be like, oh, my occipital lobe might be having an issue, and just kind of correlate them to different situations in life where you might use these different functions, and that can help you out a lot. All right, really good with that one. All right, next question. Which of the following structures can be found in the middle mediastinum? Keynote here said middle mediastinum. All right, I'm seeing more of a split in here. Let's share these results and let's go through this one. All right, so the answer is going to be the heart. And so that's one that we really want to emphasize as being as part of this middle mediastinum. Remember, the mediastinum can be divided into really half, and then you can divide it again. So we're calling this in green up top here. This is the superior mediastinum. And then collectively, everything below that extending between the lungs here is going to be the inferior mediastinum. That inferior then can be divided into anterior, middle, and posterior. So I see a good question is what's in the anterior mediastinum. So really there's just fat and some of this thymus gland in here, especially if you're in adolescence where this thymus gland is quite large. In a lot of our donors in the cadaver lab, you won't really see much of this as it's been quite shrunk at that point. But lots of fat in the thymus gland are pretty much the things you're going to find in anterior. In the middle, we said the heart. Superiorly, the big ones, big ticket items. You can see some of the stuff from the posterior mediastinum as they're making their way down into that area, but the really big ones here is the arch of the aorta and branches from these large vessels as they're coming through here. And then also through this posterior mediastinum, we can see the esophagus, inferior vena cava sort of poking out the back over this way. You can see the thoracic aorta is going to be a really big ticket item in that posterior mediastinum as well. All right, and so the lungs was one. You guys did a good job of not getting caught up on that one either, but those are going to be on either side in the pleural cavities, not part of the mediastinum. All right, you guys are doing excellent. Okay, another really good question. There's a lot of regional objectives associated with the heart, a lot more than some of the other sections, so I just wanted to make sure that we dedicated some extra time here. So next question, which part of the heart's conduction system is responsible for rapidly transmitting the electrical impulse to the ventricles, causing them to contract? This one might have been a little confusing in the wording since some of these things are eventually getting to the ventricles, but it's a good conversation we could have nonetheless. All right, I'm sorry about that confusion, guys. Let's talk through this one. All right, so the answer that I was looking for was Purkinje fibers, but a lot of you guys were focusing on the main ticket item here, and this was the sinoatrial nodes. This is what your heart's natural pacemaker in here. And so this is going to send our electrical impulses from this SA node to our AV node, which will do more of sort of a relay station and sort of slow down that electrical impulse and coordinate it between our atria here so that we can coordinate when we're contracting and when we're filling these areas here. So then you have this bundle of his bundle. You can see that that's going to divide into a right and a left. And so then the Purkinje fibers are the ones that are actually in the ventricle. So that bundle of his was in this interventricular septum here. And so then these Purkinje ones are the ones that are actually going in the ventricles and transmitting that. So maybe a better way I could have worded this question would be directly to the ventricles or something like that. So I'm sure you guys were focusing on the big ticket item here, which is what I'd prefer you guys to do anyway. So good job nonetheless. All righty, next question. Let's do which lung or lungs has or have a cardiac notch to accommodate the heart? one is, you guys did a really good job on this one too. Let's share those with you. So one thing that's helpful is just thinking about where the heart is, how we talked about that it was situated sort of just to the left or adjacent. So that just makes a little bit more sense than how we have this cardiac notch on the left lung to accommodate that extra space for the heart. So that's why this one's really important clinically, also just kind of knowing where that sort of spot would be if you're going just anterior, then where you can maybe see this heart sort of poking out, and how we have this cardiac notch on that left lung to make space for that. So that's something that you could see on your donors as well when you guys get a chance to go into the cadaver lab. And we're all very excited to have you in there for what is, for many of you, your first time in there. So maybe that's something that we could show you guys too on the cadaver for the exam when we do our sort of introductions. And additionally, I encourage you to look at your anatomy atlas. I think that's a really good spot where you could see sort of some differences here. So I see a notch is very large. It can be. It also depends on the size of the heart. What you'll notice sometimes is that because some individuals have enlarged hearts, then that there's just less space for the lungs in that situation. And so you'll notice that notch is actually going to be even larger in some individuals than it is in others. So others might not be as obvious, and that just might be some anatomical differences as well. Great job with that. Couple more questions left, and then we'll move on to the standardized patient. Alrighty, so which of the following is a retroperitoneal structure? This was a hard concept for me when I first took anatomy. All right, you guys are a lot smarter than I am, so you guys didn't struggle really as much. But if you got it wrong, don't be upset. I got it wrong when I first learned it, and I still made it through school just fine. So I promise it'll be all right. All right, so the answer here was the kidneys. And so I just wanted to cover this topic, and really, I really wanted to make a question about this because I think it could be quite difficult. So this is a list of intraperitoneal versus retroperitoneal structures here. There are some that are a combination of both. I don't really think that you need to worry about focusing on any other lists that you find online. If you just keep it concise enough to these definitions, I think that is excellent for your level where you're at right now. And so just a reminder that you're not going to be within that peritoneal cavity. That's space that should be empty anyways. And so this is just referring to the way that this visceral peritoneum is enveloping these structures. So you can see, for example, the small intestine is predominantly one of these intraperitoneal structures. Duodenum is actually going to be a combination of both, but let's just focus on jejunum here. You can see how this is fully enclosed or wrapped by this visceral peritoneum versus some of these other structures like the ascending colon. You see it's listed as retroperitoneal, how just this anterior surface of it is covered with that. So that's what that means. Again, if you guys are struggling with this concept, again, I encourage you to look at YouTube videos. Feel free to email us if you have questions or ask your teachers, because that's one that just confused me. Because when you say intraperitoneal, it sounds like it's going to be inside, and that's not quite the case. Alrighty, next question. Let's move on to which structure of the nervous system is responsible for parasympathetic innervation of most of the digestive system, stimulating activities such as increased secretion and motility? We got most people in here. All right, so we struggle with this one a little bit. So a lot of you said the sciatic nerve. So has anyone here had sciatica? I'm not sure if you have or not, but or if you've heard, maybe your parents or siblings or something complaining about having sciatica. So that's your nerve that's going to be predominantly innervating the muscles in the back of your thigh and all throughout your leg and your foot. So this is going to be more of our a somatic nerve that we have here. As far as parasympathetic goes, we were looking for the vagus nerve. See here that we've got a vagus nerve. It's one of our cranial nerves. You can see here that we've got some inputs to the heart, to the lungs, and then a lot of our digestive system here. also interacting with some structures here down in with our pelvic nerves, getting to more of our pelvic structures here. But you can see parasympathetic innervation largely from this vagus nerve, especially to this digestive system. So think vagus. You might have heard of vagal tone being mentioned in some scenarios, and so that's also keying into digestive system there. Alrighty. Vagus nerve, when you can to stimulate with deep breathing to calm down. Yeah, so you're going to get parasympathetic inputs to the heart. So yeah, exactly. That's one that you can definitely use to, we said parasympathetic is going to be slowing down your heart rate versus sympathetics would be increasing. So stimulation of your vagus nerve or those parasympathetics would decrease your heart rate. So that's very good. All right, and this is my last question for you guys before we jump over to our standardized patient case. And so it's, which of the following is not true of the pelvic floor? Let's see how you guys do with this one. Pelvic floor is kind of a complex topic. All right, you guys are again just doing awesome with this. All right, let's share that. So the imposter in here was that it's only found in female individuals. So this is going to be a structure that is for both male and female. This just makes sense when you're looking at some of these other examples too. If you're thinking maintaining urinary and fecal continence, both male and female have that. We got to worry about it. Resisting this increase in abdominal pressure and supporting those organs that are sitting just above it. Whether you're male or female, you got to do that. And then these are your two muscles that were of concern, your levator ani, which can actually be divided into several muscles. You don't need to worry about those. And your coccygeus muscles. So those are going to be your primary ones to worry about with pelvic floor. But you guys did really good with that. All right. So that's all the questions that I have for you. Oh, here we go. Here's also the really good slide from Dr. Veazey's lecture that I wanted to share with you guys, again, including your main components that you need to know for what's making up this pelvic floor. And again, this urinary and fecal continence is something that's really important with this. And there's a lot more newer research, I think, coming out of studying the pelvic floor. So it is very important. And the implications, especially of this pelvic floor in females due to childbirth. So that's something that definitely won't go away if you're interested in medical professional. All right, so let's go through the standardized patients with the rest of the time, and then we should leave plenty of time for Dr. Peterson to go over embryology, which I know a lot of you guys could really use some extra help with. I know I did, and I still do sometimes. So, all right, standardized patients. So these again are going to be in medical education. It's someone that's been trained to present the signs and symptoms associated with this specific disease or disorder. So this is something where if you're interested in medical school, you will absolutely encounter. All right, so for us, you can expect to encounter 10 of these. They'll be located in separate classrooms or maybe at different stations in a larger room. And these are going to be at each regional site. So they will be identical. So you'll get the same ones as the people. If you're coming down to meet me in Auburn, Alabama, it's going to be the same people. If you're meeting Dr. Haggerty in Thomas Jefferson in Philly. So you'll get 5 minutes total for each SP interaction. And that's something that I realized from putting this together that maybe that part wasn't on the website. But we're going to go through an example of that and give you 5 minutes as we work through one. We are going to randomly assign you to work with one other individual. So you're not going to be sharing answers, but you will be exposed to the questions that that other student is going to be asking. So how this is going to work is that a standardized patient, for a lot of us, we've got our medical students that actually volunteered to present these illness scripts. And so that might be a medical student at VCOM Auburn, for example. And so this is going to include different demographics about this patient, typical things that you would intake on a form that might, key them into some sort of diseases or anything you'd want to know as someone taking care of someone. And so you'll get a history of the present illnesses, for example, signs and symptoms, and time course, whether it's happening more recently or if it's something they've been struggling with for quite some time. So where this counts now, where you have another individual with you, is that you're allowed to ask 2 questions from a list provided. And so how that will work is that we'll assign you as either student A or student B. And so if student A asks the first question at one SP followed by student B, then student A will ask and student B will ask again. So a total of 4 questions. When you get to the next encounter, then you'll alternate rows. So then student B will get the next opportunity to ask the first question. So that way it's a little bit more fair. These SPs can only respond to the questions that we have given them in advance. And so it has to be from the list of 11 that we will provide to you. And they can only be yes or no answers. So you won't get anything besides a yay or a nay. All right, so these responses are standardized, same at all regions, no matter where you're at. All right, so we are also going to provide you with the list of the 40 possible Anato-Bee standardized patient cases. These are found on our website under the lecture objectives tab. I'll show you where to find that next. All right, and so then you will mark each diagnosis on a form, and we'll show you how to work through that once you get to regionals, and you'll submit it for grading. And we won't provide you with anything for this subtest until the completion of the competition. So where could you find these SPs if you haven't looked already? If you go to our website and then you click on this resources and forms tab and you click on the learning objectives, and you scroll to the bottom, then you could find the standardized patients. And so this is a list of identified 1 through 40 cases that could possibly show up. So it's limiting it to just those 40. So it's not like it's going to be anything under the sun. And you should just focus really on the basics of each of these cases. A lot of the scripts that we have written are sort of caricatures almost of these cases to make it quite pronounced or the most obvious of the cases within there so that it's not ambiguous for you. All right, so these are your 11 questions that you would encounter. These are also listed under the 2024 regional competition tab to help you find those. So if you want to just practice going through these 11 questions for any of those, you can. But what I would do more so is focus on the ones that you think would be associated with a certain illness. For example, if something is congenital, then asking if you think it's that case, then you should ask them if other families have similar symptoms to see if it has a genetic component in there. So you could also see if it's been present since birth. That would be another really good question to ask someone when you think that it's more of a congenital illness. If you're thinking it's something more of like cancer, for example, number 6 would be a really good question to ask. Do you think has something to do with this uncontrolled cell division that might sort of have a role in here? There are a couple in here that might be a little bit more ambiguous to ask that could be applied to quite a few things like lifestyle choices, environmental factors, but you do get a total of 4 questions between you and your partner in there. So that could be good to really hammer it home if you think that it was related to something and sort of differentiate between these cases. All right, so I'm going to go through a first example. So in total, you get 5 minutes again. So I'm going to start a timer now for 5 minutes because you'll get it from the moment that the SP interaction starts. You'll get to ask your questions and then you get to write your answer down and then rotate to the next room. So I'm going to start the timer now while I read this first case. All right, so you're pretending to be the doctor. So, hey, doc, this is Sue, my grandmother. Thank you for seeing us today. About a year ago, my family and I started noticing that grandma is more forgetful than normal. It first started where she was misplacing her keys to her car or she would leave her purse when leaving the house. We thought it was just normal things that happen when you get older, but it's getting a lot worse. 6 months ago or so, she started repeating the same stories after immediately finishing them. I just don't think she's repeating herself because no one's listening. It seems like it's happening unprovoked. I think the most concerning change that we noticed started this past week. She used to be a photographer and she taught me how to use her camera when I was just a kid. She's traveled all over the world and taken the most beautiful photographs of nature, people, pretty much anything you can think of. So recently, Grandma's had a couple mornings where she doesn't know who she is or what's happening when she wakes up in the morning. She even asked me what the camera was next to her bedside table for, asking if it was mine and if I could teach her how to use it. She always gets back to being herself in a couple hours, but we're worried that one of these times she's just going to forget everything. It really started impacting her everyday life and the lives of our family. My grandma has been in pretty good health for as long as I can remember, so it's really hard for me to see her like this. What do you think is happening to my grandma? All right, so these are your 11 questions. If you guys want to type a number in the chat, and then I will answer them for you. I'll just do the first people. Okay, so the first one I saw was 3 is, do other family members have similar symptoms? And not that I've seen yet. I haven't seen anyone else in my family that's had this. Also seeing 11, would sending me to diagnostic imaging aid in my diagnosis of the illness? And I think that would. I think that would probably help me. All right, 4, have these symptoms gotten noticeable as you've gotten older? Yes. And finally, what I'm seeing in here, 8, have they gotten much worse or worsened over weeks to months? And I'd say yes to that one too. So that's our 4 questions for there. So here are your list of possible illnesses. That was about 2 minutes in. So you still get 3 minutes to kind of work through these I answered those questions quite rapidly, so if you'd want to take a little bit more time to ask the questions, there's a little bit of time in there, but go ahead and think for a minute. Don't type it in the chat yet, but just think for a minute about what disease you think this could be. And I'm gonna wait till 5 minutes is up. We still have about 1 minute and 15 seconds, so that's showing you that I think 5 minutes is tons of time to think through these. How are we feeling? Do you guys wanna try putting some answers in now and see how we do? Yeah, lots of 21s. Oh my gosh, you guys are rock stars. Absolutely, that is what we were going for, was Alzheimer's disease. All right, so hopefully that gave you a better insight in terms of what this would look like. I will say for some of those questions that we had brought up before, you might be able to adapt the questions slightly so that they suit your needs better. For example, when I just presented that case, I was talking on behalf of my grandmother. But if, you'd have the same thing, you could have where you're talking for a child or, someone that might be nonverbal, then you can adapt the questions and say, for example, would your son benefit from diagnostic imaging? So if you word the questions a little bit different, then we're okay with that. Just try to stick to the major content so that you're still getting the same yes or no answer. So I hope that helps. Dr. Peterson, anything you'd like to say about these standardized patients?
I think it's more about almost critical thinking. So if it were me, I know William was asking, well, you've never tutored us on pathology, but you all are great critical thinkers. And so if it were
Yeah,
me,
I think I'm a little bit more confident. I see what we're doing because I see there's only 40 different diseases and they're all about covering across different systems, which narrows
right,
it down a
and
lot.
some of them are definitely diseases or
Yeah.
syndromes associated with the newborn, new or young children, others for the elderly, and then you have some that would be more appropriate for adults. So I think thinking about them in that way and then asking yourself, well, again, is it something that's, just came on very, very quickly? So it's only just like within the last day or two that the symptoms have gotten worse, or if it's something that's chronic, that even just those asking yourself those kind of mental questions, I think will help you tremendously. All right.
I'm gonna turn things over to you, Dr. Peterson. You guys did such a great job with all those. I'm seriously just more impressed every time I get to interact with you guys.
Me too. So, Dr. Priskura, I know that Dr. Haggerty really wasn't sure if she could stay through the entire session today.
I
Do
can
you
help you
want to
with
run?
polls.
Yeah, perfect. And I'm gonna try to share my screen. And it's not that one. Okay. All right, can everybody see me and hear me? And if you could just answer me, Dr. Piskura, because I don't have another monitor set up, so I won't be able to see the polls per se.
Yeah, I can see and hear you. I don't see your screen yet.
Okay. How about now? No?
Not yet.
I shared. Okay. Let me, so, yeah.
Are you still seeing the option to share your screen?
I am, but not my PowerPoint. It's not coming up. Do this. No. Okay, hang on. Maybe you could just go ahead and talk a little bit more about the competition and what they have to look forward to, and I will once again try to open up my PowerPoint and get a sense of what's going on.
Yeah. If you hit a point where you can't get it, I can try to pull it up on my end too and advance them for you. But yeah, in the meantime, we got the medals and trophies in the mail and dispersed out to all the regional host sites. So that's been super encouraging to see, and we're just really excited to have you all here. I know there's different things going on a little bit at different campuses. I can see your screen now, Dr. Peterson.
Nifty. Okay. Don't know what the snafu was, but let's get started. Okay, so I just wanted to let all of you know that mine is just going to be a learning objective, so RLO, regional learning objective, and I have a question for each of the new embryology learning objectives, and there are 17 of them. I'm hoping that we can get through most of these, but I might, as we get towards the top of the hour, I might skip a few, but I'll at least show you the question so that it's on the recording so that you can go back and take a look. I am not going to read the questions to you so that you have just quiet time to really process the question and your answer choices. So let's go ahead and put up a poll if you would. And Dr. Priscilla, maybe when we hit 10 out of the 14, we just end the poll so that we save enough time for the discussions as well.
Perfect. We've got 11, so I'll go ahead and stop that now.
Okay, so it looks like everybody was kind of torn between A and B. I'm going to go ahead and show you the correct answer and we can talk about this. So again, this is the question, and last known menstrual period was 5 weeks ago. I'm reminding you that we have two different ways to calculate the age of a developing embryo. So it either begins at fertilization, so the total gestational time is 38 weeks, or we use gestational age, and this is calculated from the first day of the last menstrual period. And this was Kate LaJoy's very first tutoring session that she presented this. So again, we have that this embryo is at 5 weeks of embryonic age or 7 weeks of gestational age. So it is kind of important to keep track of the developmental timeline. Recall that the cardiovascular system is the very first of the organ systems to develop, and we've talked about why that is, because this mass of cells is just, it has too many cells to be able to support itself through some kind of diffusion. So cardiovascular system first to develop around 3 weeks. Then we said at 4 weeks, it's the neural or nervous system. And then respiratory system develops shortly thereafter. And then the gastrointestinal system, which is what this question was asking you about, that primitive gut tube really is in place by about 5 weeks. And that really kind of is in relativity to what the question was asking you. So C would be the best answer for this question. Right? So let's go on, and I don't want you to get discouraged. I think you can learn a lot in just thinking about these questions and being fearless and putting up an answer, and then you'll gain a lot from the answers as we go over these. Okay, next question. All right. Are we going to go ahead and end the poll just for the sake of time? Okay, and it looked like it was a neck and neck race, mostly between A and B, and then a couple of you thinking that it might be D. So let's go over this. I wanted to review again with all of you that when we think about, and you see the picture up here, I tried to highlight as best I could that this again was from Kate's tutoring session. So what you're seeing is we have the endometrial lining. So this is that innermost lining of the uterus where implantation occurs. We're far enough along that we have had these outer cells that are associated with the outer cell mass. So you're seeing those here in this orange color. They have actually degraded and moved into the actual tissue of the uterine lining. And that's where we're going to get the blood supply ultimately, and where the placenta is going to begin to form. So these outer cell mass cells are part of what we call the trophoblast, and that included the cytotrophoblast and the syncytiotrophoblast. And Dr. Haggerty used this term in the histology review earlier tonight. Syncytium just means a mass. So there is no clear boundaries between the cells in this glob of cytoplasm. So those are all nuclei of different cells associated with the trophoblast. And then I saw that some of you had selected answer choice D, and remember that that is really the inner cell mass. So you see that that inner cell mass, sometimes called the embryoblast or the embryonic disc, consists of epiblast cells and hypoblast cells. And we're seeing that epiblast here in blue, and we're seeing the hypoblast here in purple. The epiblast cells, everybody listen to this carefully, the epiblast cells are the cells that will become the embryo. The hypoblast cells are the cells that will give rise to the yolk sac, which is also in some of the tutoring sessions, it was referred to as the umbilical vesicle. So a lot of information. I know this is a difficult material, but it seems like you all are processing this pretty well. So we'll go ahead and I'll move on to the next slide and the next question.
One thing I'll say really briefly too is that on our end, I can't see who voted for what. So you're not making a fool of yourself or anything if you just put yourself out there and guess and, take a shot and see how you do.
Perfect. Be fearless. Again. All right, we should probably, again, for the sake of time, go ahead and it looks like a lot of you, though, took some clues. So I want to, before I show you the correct answer, again, we're talking about a signaling structure that we refer to as the notochord, which is that middlemost germ layer, the mesoderm. So remember that gastrulation had to have occurred, and our epiblast has now become a trilaminar disc with an ectoderm, a mesoderm, and an endoderm. And most importantly, the clue here is that we're in week 4. And based on the question we just talked about previously, remember that it's in week 3 that we start to develop our primitive heart tube, so the cardiovascular system, and it's in week 4 that we begin to develop our nervous system. So the correct answer here was going to be answer choice B, so the neural plate, which you see here, which ultimately will give rise to the neural tube. And again, this was from Gabe Costa's lecture, just showing you here's that middlemost layer, the mesoderm, everything being color-coded with the universal color of the embryonic mesoderm, which is red. There's that midline structure, the notochord, and we're seeing that then sonic hedgehog, that signaling molecule, would be able to diffuse to the uppermost ectoderm layer and cause specialization within the ectoderm. So we call that specialized neuroectoderm, which again will give rise to the neural tube. So you did really well on that one. And I thought, yay, let's include a little picture of my favorite cartoon character, Sonic Hedgehog, so that you'll remember that maybe on the written exam next weekend. Okay, gonna go ahead and we'll move on to the next question.
It's right about 10.
Okay, so maybe Dr. Priscilla, because they can see both you and I, what Dr. Frank used to do was give them a kind of countdown, 3, 2, 1. Maybe we can start doing that so we get everybody an opportunity to put in an answer. So let me go ahead and just point out a couple of things that might have been clues to answer this question. So again, we've got a failure of the vertebral arch to close, and both the membranes that surround the developing spinal cord and spinal nerves are going to be found outside of that vertebral column or the vertebral spine. So this is from Dr. Spudik's lecture, and I'm going to show you the correct answer. And so that is and I know these are big words, that is what is called a myelomeningeocele. So spina bifida occulta, remember, she said, is oftentimes not even, it's kind of oftentimes not even diagnosed because the skin will close over that small crevice in the vertebral arch that didn't completely close. And all you have there is skin and sometimes a little tuft of thick, dark hair that's indicative that you had some inappropriate sonic hedgehog signaling. When we talk about a meningeocele, you see that you've got the meninges that have pushed up through the crevice in that vertebral arch. Since it didn't close, it's just the membranes that are trapped out there. And that's serious, but it's not nearly as serious as a myelomeningeocele, which is what this picture depicts, where not only are the membranes, the meninges trapped, but spinal nerves are trapped and compressed, which can actually over time cause deterioration of those spinal nerves, especially we're usually in the lumbar region. So you see lumbar vertebrae here. So those are nerves that are going to the lower limbs and can lead to paralysis and failure of appropriate pelvic organ function. So you oftentimes lose control of the bladder and the pelvis in this particular type of disorder with a failure of those neuropores to close. So great job, and we'll move on to the next question.
Pull in 3, 2, 1.
Okay. All right. So I just wanted to point out a couple of terms that we've mentioned in previous tutoring sessions. So remember, soma in Latin is just the root word for body. So we're talking about mesoderm, and remember that's our middlemost layer. And if just as a reminder, mesoderm forms really all types of muscle. So skeletal muscle, smooth muscle, cardiac muscle. That's the mesoderm. It also forms all of the connective tissue, and all of the blood vessels. So if you just even know that much, you're ahead of the curve for where most medical students actually start out in embryology. And remember, lateral plate mesoderm is that is furthest away from the notochord. So we're talking body, lateral plate mesoderm, and we want to know the major contribution to this diaphragm, which we were reminded earlier is skeletal muscle. So I'm going to show you the correct answer and a picture from Dr. Veazey's lecture. So this is the septum transversum. And again, I think Dr. Haggerty talked to you about septum as something that separates, in this case, body cavities. So we're separating the thoracic from the abdominopelvic cavity. And it is kind of complicated, but this was not a complicated question per se. The major contribution is from this mesoderm that is going to give rise to the skeletal muscle. So it's septum transversum. There is some small contribution from here at number 2, this esophageal mesentery. Third contribution are these membranes, but it's the pleuroperitoneal membranes, which are forming around the right and left lung. And then there's a small sort of contribution, and this is why I had to say major. There's a minor contribution of skeletal muscle actually from the body wall itself. So great job on that one, and we'll go on to the next question.
I'm going to go ahead and close the poll in 3, 2, 1.
All right, nice job, everyone. So the correct answer is answer choice B. I believe that this was Whitney that gave this, if I'm remembering correctly, from Dr. Pescura's home institution. So I think she pointed some of this out, as well as was it possibly
I'm gonna give
Natalie? Was it Natalie?
Natalie Saliba, who is a phenomenal artist and medical student we have that created all of these images. Yeah.
Right, so I'll just talk you through what she was trying to show you. So she gave you down here a small little legend, but there's our neural tube. She was trying to show you again that your neural tube, and then right here would be where we had our notochord, and that's again in the mesoderm. So we are in this region closest to neural tube, and down below it our notochord, and we would have those different regions of paraaxial mesoderm, intermediate mesoderm, and then again, lateral to that, the lateral plate mesoderm. But all the action here is in the paraaxial mesoderm, where these paired structures along the length of the notochord are forming, and we call those somites. And the somites then, red star here, the somites then further specialize into this sclerotome region and then this dermamyotome region, which will ultimately develop into dermatomes, giving rise to the connective tissue of the skin. The myotomes, again, to the skeletal muscle of the body wall, and sclero in Latin as a root word means hard. So the sclerotome is that region giving rise to the hard, bony materials that are ultimately, and look at their close proximity to the neural tube, are going to form a protective cage around the neural tube, and that, of course, is the vertebrae. So you did great on that. All right, we'll go to the next question. And this is a question probably near and dear to Dr. Pascura's heart as well as Dr. Haggerty, because they love anatomy.
Go ahead and close this poll in 3, 2, 1.
All right, so great job on this question as well. So correct answer was what most of you chose was answer choice B. That's terrific. And I think this was Dr. Oriana, if I remember, that talked a little bit in our very first review session for regionals about limb rotation. So this is just to give you a size scale of the size of the embryo when we're talking about week 7 or 8 when limb bud rotation occurs, not even 2 centimeters. So not even an inch yet is the actual length of the embryo. What we're trying to show you with this image is that the limb buds are going to just bud out almost directly, and then we need rotation in opposite directions for the upper extremity versus the lower extremity. So you can see that the upper extremity, the joint here, the elbow joint, is going to rotate posteriorly, and everybody reach down and touch your knee. The knee joint, we know, ends up anteriorly. And this is what sets up with this rotation in opposite directions of the 2 sets of opposing limbs, sets up this idea that the flexors are in the anterior compartment of the upper limb, but our major flexors for the lower limb are localized posteriorly. And this is just for me to be able to say, you know, I know embryology is hard, but most medical students tell me after they've finished their study of embryology, oh my gosh, embryology, Dr. Peterson, it explains everything. And it does, because it was the start of everything. So keep that in mind. I know it's a struggle, but keep trying. Okay, let's go on to the next question.
I'm going to go ahead and close the poll in 3, 2, 1.
Okay, so I think all of you are awesome test takers by this stage in your high school career. So maybe you noticed that there were 3 answer choices that had septum in the answer choice. And then there were 2 that had cardiac kind of embedded in them. And we are talking about the primitive heart tube, so all of that makes sense. But again, looking for clues, the separating structure, and again, think of what you now know is sort of the definition of a septum. It separates one large something into smaller somethings. So hopefully that would have allowed you to at least eliminate some answer choices. And the correct answer choice is, in fact, D. And I just wanted to use this particular, I gave you the YouTube site. It's called, I think she calls it Mini Med Bites, but it's a medical student that's very artistic, and she does really awesome illustrations, and she talks you through the embryology in a way that's really easy to understand. So you might spend, some time trying to play those videos at double speed, like the medical students do. So just showing you what we kind of gave you as clues in this question. Remember that the truncus arteriosus is the most distal end of the primitive heart tube. And by that, I mean it's closest to the cranial end where the brain is forming. And then we're showing you here that that truncus arteriosus in purple, when that primitive heart tube folds, it winds up being really the base of the outflow tract where blood is going to leave the ventricles. And this is what has to get separated so that as it comes out of the right and left ventricle, it's able to be directed to its very different terminal targets. And as all of you are well aware, we're separating it into the pulmonary trunk and then those pulmonary vessels that are directing blood to the lungs, and the aorta, which is directing blood to the body. And so what you're seeing over here is just the different growth in different regions of a membrane, that spiral septum, that's growing from different aspects of that outflow tract to create a spiral membrane, which is the spiral septum. So great job on that question as well. Okay, let's try this next one.
I'll go ahead and close the poll in 3, 2, 1.
All right, it was close, but the majority of you did select the correct answer, which was answer choice C. So again, this is coming from that same website. We're showing you the placenta here. We're showing you blood, oxygenated blood, leaving the placenta and moving in the umbilical vein, trying to make its way as quickly as possible to the primitive embryonic heart. So some of it will go into the liver, but a large majority of that blood gets shunted around the liver in a little shunting vessel called the ductus venosus that will drive it right into the inferior vena cava so that it enters the right side of the heart and then can enter the systemic circulation. So really you should take maybe a second look at Emmeline Whitwer's tutoring session. She described these 3 different shunts that are in place in the fetal circulatory system that are pretty important. So we don't have time to go over those now, but again, spend some time with that. I think it will come back to you better and quicker than you think it might. So we'll move on to the next question.
You guys responded pretty quick to this one, so I'll go ahead and wrap it up in 3, 2, 1.
This was great. And I love when you have fewer choices. And there will be some of the questions on the written exam, just like this, where you have sort of a limited number of choices, which hopefully makes some of these more challenging questions a little bit more manageable. Correct answer that the majority of you chose was answer choice C. And I'm just calling your attention to, I think, again, this might have been Dr. Carriger that went over this information with you. So a tracheoesophageal fistula, remember that there is here in blue, that's the esophagus, and the entire respiratory system is a small little bud, or what we call the respiratory diverticulum, little outgrowth that then generates the entire respiratory system, which is amazing. So you guys did great on that. So we'll move to the next question. And this should go pretty quickly. We'll do this one pretty without too much time.
Close this one off in 3, 2, 1.
Okay, so sometimes the easy ones are the ones that get us. So again, this was in Dr. Carriger's. Am I pronouncing it right, Dr. Pesquera?
Harriger.
Okay, so sorry. My apologies. So again, the correct answer is actually one that no one chose. So the correct answer choice A. So all, and this is phenomenal. All of the bronchi have actually developed in that first embryonic period. So try to keep that in mind. And then there's this overlap that we talked about. So we start to develop the bronchioles in this next phase, which we call the pseudoglandular. The big deal here is where gas exchange can start to occur, happens in this canalicular phase between weeks 16 and 26. So those are the respiratory bronchioles. The saccular at 24. So in a way, it's kind of it goes by eights if you kind of want to get the numbers right. So 8, then 16, 24-ish, and then to full term, and beyond. So we kind of talked about the alveolar stage really goes at least until puberty, when you're just seeing a huge increase in the number of alveoli and the capillaries that surround those. Okay, so we'll go on to the next one.
This looks like we got a majority. So let's say in
Yeah,
3,
let's-
2, 1.
Excellent. And the correct answer is Answer choice B. So remember, I think this is the important information. There was a lot of information in Dr. Sputik's slides, but I think if you keep kind of focused on foregut, midgut, and hindgut, and the branches listed here, celiac trunk for the organs of the foregut, midgut is superior mesenteric artery, and hindgut, inferior mesenteric artery. You'll be just fine on these questions next weekend. So we'll go ahead and do the next question.
Gonna get your responses in 3, 2, 1.
All righty. So overwhelming response for C, which is the correct answer. And recall that ureteric bud, as was stated in the question, is just a bud off of the mesonephric duct, and that it induces this metanephric mesenchyme, or we called it the metanephric blastema. And so I think the easiest way that I remember it is the ureteric bud gives rise to the ureters and all things that are more macroscopic that I can see with my naked eye when I look at a model or an actual harvested kidney. So that would include things like the ureter, renal pelvis, major and minor calyces, and then again, this metanephric blastema is what gives rise to all the microscopic structures of the nephron, except for the glomerulus. And that just is derived from some mesenchymal cells in the proximal mesoderm, because again, mesoderm gives rise to blood vessels, and that's what the glomerulus is. So we'll try this next question.
Alrighty, and get your answers in 3, 2, 1.
Okay, excellent again. So correct answer was answer choice A. And I just want to point out that Dr. Veazey talked a little bit about this. So again, we're talking about thin tentacle-like extensions from the chorion. And so those are villi, microvilli associated with the GI tract. And then she said very clearly in her presentation a couple of weekends ago, if it says deciduous, it's part of the maternal endometrial lining. And the chorion, as we just said at the beginning of the review for embryology, the chorion is fetal associated tissue. So you did a great job on that. I think we'll do one more question, and then I'll just show you the remaining 2 questions and the correct answers so that they're on the recording. So let's try one more for tonight.
Alrighty, in 3, 2, 1.
All right, I feel like you all got your embryo mojo going here towards the end of the question set. So you are correct. And I gave you what I hope is a nice, concise sort of summary table that comes from, for you all, it comes from a textbook we actually recommend that medical students refer to. So again, I have this on this summary table on the remaining slides to help you out. And I just want to point out a couple of things. So over here on the left-hand side, take note that this is the pharyngeal groove that's being depicted. So we see groove 1, 2, 3, and 4. Over here on the far right, you see that that's showing you the pharyngeal pouches, 1, 2, 3, again, and 4. And then the arches are here in the middle. They have a cranial nerve associated with them. They have muscles associated with them, and they have these skeletal derivatives. And that's what we're trying to show you here. Here's the arch number. So let me show you the remaining questions, which are all on the information that Dr. Spudik reviewed with you last time on the pharyngeal apparatus. So here's question 16. There's your answer, because this was about the pharyngeal groove. And remember, she said there's really only one, and this is now thought to be information that's changing, but we're still going to go with what we know for certain about embryology on the regional competition exams. And then the last one is here. And this was a question about the pouches, and the thymus gland, as you can see, is derived from pouch number 3. So I thought you all did really, really well. I am going to end my PowerPoint, and I'm going to stop sharing my screen. I hope. Really, I'm trying. Okay, so that we can say, and I'll start off just wishing you all the best, and I hope you have just the experience of a lifetime.
Yeah, same thing. Just thank you for participating in our first year. It's really encouraging to see on our half, and we really hope that if you don't get to where you want to be in the anatomical sciences this year, we are very encouraging to keep having you back at these sessions in the next year. So thank you.
And keep in mind, just because you do not come to the Anato-Bee, it does not mean you will not achieve a career or education in the anatomical sciences. There are many ways to get to where you want to be, especially if you are willing to achieve that pathway. And we are here to also assist with that. So again, because you do not go to the Anato-Bee, doesn't mean you cannot reach out to us for guidance or help, or have us connect you to somebody who can do that for you. So great job. We are really excited to see those of you coming to the regional competition, and those of you who are not, we hope to see you next year. And we're happy that you came and joined us this evening.
Thanks, everyone. Take care and safe travels if you're making your way to the next regional competition. Bye, everybody.